Cancer of the pancreas. Cigarette smoking, exposure to industrial chemicals or toxins in the environment, and a diet high in fat, meat, or both are associated with pancreatic cancer, although their role is not completely clear. The risk for pancreatic cancer increases as the extent of cigarette smoking increases. Diabetes mellitus, chronic pancreatitis, and hereditary pancreatitis are also associated with pancreatic cancer. The pancreas can also be the site of metastasis from other tumors. Cancer may arise in any portion of the pancreas, that is, in the head, the body, or the tail of the pancreas. Clinical manifestations vary depending on the location of the lesion and whether functioning insulin secreting pancreatic islet cells are involved. Approximately 75% of pancreatic cancers originate in the head of the pancreas and give rise to distinctive clinical picture. Functioning islet cell tumors, whether benign adenoma or malignant carcinoma, are responsible for the syndrome of hyperinsulinism. With these exceptions, the symptoms are non-specific. The patients usually do not seek medical attention until late in the disease. 80% to 85% of patients have advanced unresectable tumor when first detected. In fact, pancreatic carcinoma has only 2 to 5% of survival rate. Clinical manifestations. Pain, jaundice, or both are present in more than 90% of patients and, along with weight loss, are considered classic signs of pancreatic carcinoma. However, they often do not appear until the disease is far advanced. Other signs include rapid, profound, and progressive weight loss, as well as vague upper or mid-abdominal pain or discomfort that is unrelated to any gastrointestinal function and is often difficult to describe. Such discomfort radiates as a boring pain in the mid back and is unrelated to posture or activity. It is often progressive and severe, requiring the use of opioids. It is often more severe at night. Relief may be obtained by sitting up and leaning forward, or accentuated when lying supine. Malignant cells from pancreatic cancer are often shed into the peritoneal cavity, increasing the likelihood of metastasis. The formation of ascites is common. An important sign when present is the onset of symptoms of insulin deficiency, glycosuria, hyperglycemia, and abnormal glucose tolerance. Thus, diabetes may be an early sign of carcinoma of the pancreas. Meals often aggravate epigastric pain, which usually occurs before the appearance of jaundice and pruritus. Assessment and diagnostic findings. Magnetic resonance imaging and computer tomography are used to identify the presence of pancreatic tumors. ERCP is also used in the diagnosis of pancreatic carcinoma. Cells obtained during ERCP are sent to laboratory for examination. Gastrointestinal X-ray findings may demonstrate deformities in adjacent viscera caused by impinging pancreatic mass. Percutaneous fine needle aspiration biopsy of the pancreas is used to diagnose pancreatic tumors and confirm the diagnosis in patients whose tumors are not resectable, eliminating the stress and postoperative pain of ineffective surgery. In this procedure, a needle is inserted through the anterior abdominal wall into the pancreatic mass, guided by computer tomography, ultrasound, ERCP, or other imaging techniques. The aspirated material is examined for malignant cells. Although percutaneous biopsy is a valuable diagnostic tool, it has some potential drawbacks. A false negative result if small tumors are missed and seeding of cancer cells along the needle tract. Low dose radiation to the site may be used before the biopsy to reduce the risk of seeding. Percutaneous transhepatic cholangiography is another procedure that may be performed to identify obstructions of the biliary tract by a pancreatic tumor. Several tumor markers, example CA 19-9, CEA and DU-PAN-2 may be used in diagnostic workup, but they are non-specific for pancreatic carcinoma. These tumor markers are useful as indicators of disease progression. Angiography, computed tomography, and laparoscopy may be performed to determine whether the tumor can be removed surgically. Intraoperative ultrasonography has been used to determine if there is metastatic disease to other organs. So the important diagnostic or magnetic resonance imaging, ERCP, X-ray findings, percutaneous fine needle aspiration biopsy, percutaneous transhepatic cholangiography, tumor markers, angiography, computed tomography, and laparoscopy. Medical management: if the tumor is resectable and localized, typically tumors in the head of the pancreas, the surgical procedure to remove it is usually extensive. Medical management: a diet high in protein along with pancreatic enzymes is often prescribed. Preoperative preparation includes adequate hydration, correction of prothrombin deficiency with vitamin K, and treatment of anemia to minimize postoperative complications. Parenteral nutrition and blood component therapy are frequently required. However, is often not possible because the extensive growth of when the tumor is finally diagnosed and because of the probable widespread metastasis, especially to the liver, lungs, and bones. More often, treatment is limited to palliative measures. Although pancreatic tumors may be resistant to standard radiation therapy, the patient may be treated with radiation and chemotherapy, that is fluorouracil and gemcitabine, FLUOROURACIL, fluorouracil, and gemcitabine, GEMCITABINE, gemcitabine. If the patient undergoes surgery, intraoperative radiation therapy, that is IROT, intraoperative radiation therapy, may be used to deliver high dose of radiation to the tumor with minimal injury to other tissues. IORT may also be helpful in relief of pain. Interstitial implantation of radioactive sources has also been used, although the rate of complications is high. A large biliary stent inserted percutaneously or by endoscopy may be used to relieve jaundice. Thank you.